Good afternoon, everyone. iTech India welcomes all the participants for today's Regional Distance Learning Seminar session. Today's topic is Differentiated Service Delivery Models, that is DSDM, and the speaker is Dr. Ravinder Kaur Sachdeva, ma'am. Dr. Ravinder Kaur Sachdeva, ma'am, is currently working as a Senior Medical Officer at Center of Excellence and ART Center, PGIMER, Chandigarh. She was associated with WHO for strengthening of routine immunization and surveillance for vaccine preventable diseases. She has published more than 26 papers in international and national indexed scientific journals of high impact and has more than 705 citations. We welcome you, ma'am, for today's session and request you to start the session.
Thank you, Shweta, for the introduction. So I'm going to begin with the session. My topic is differentiated service delivery models, and I'll be telling you about this various differentiated service delivery models which we can offer to our patients in our ART center settings. Next, please. So the session objectives is to describe the differentiated service delivery models. I'll also give you the concept of patient-centric care and various types of such models and examples on differentiated service delivery model interventions. So actually, differentiated service delivery models, it was previously called as a differentiated care. It's is a client-centered approach which simplifies and adapts HIV services across the cascade to reflect preferences, expectations, and needs of people who are living with HIV and vulnerable to HIV, while at the same time reducing the unnecessary burden on the healthcare system. This means actually changing one thinking about how to provide HIV services in different group of patients are best switched to differentiated models of service delivery at different points along the HIV treatment pathway. Historically, our approach is to manage HIV patients by the one standard delivery model, where patients are expected to come to our facilities to get HIV test done, and if found positive, they are expected to report to our center. Services at one facility is to be given as per the ART center. So next, please. This is an approach which simplifies and adapts HIV services for better provision of providing services to the needs of people living with HIV, and at the same time optimize the available resources in the healthcare system. And this approach can be applied to prevention, testing, and treatment, and it has the potential to address multiple diseases, not just HIV. Next, please. Differentiated service delivery is a person-centered approach to HIV prevention, testing, and treatment. And this is actually moving away from a one-size-fit-all model. Differentiated service delivery will actually tailors HIV services to diverse group of people who are living with HIV while maintaining the principles of public health approach to enable high quality services. Next, please. I'll actually now provide you with an abbreviated process approach to differentiate ART delivery services, to identify the client and health system challenges, and to define for whom we are going to differentiate, and to determine the appropriate building blocks for differentiated ART delivery from our identified people who are living with HIV. These building blocks are the key components for building a differentiated models of service delivery. This is previously described as the key factors in the differentiated approaches to HIV care. These actually center on four questions. When is the care provided? Where is the care provided? Who is providing the care? And what care or services are being provided? The HIV person. Client is at the center of all models of differentiated care. And model of differentiated ART delivery, it should consider the building blocks for ART refills separately from those for the those people who have come for the clinical consultations. So by when, we mean that when should the dispensation, if we have done the dispensation, when should we call the next time our patient, whether it is monthly is to be seen, or is to be seen at 2 month interval, or 3 months interval, or at 6 months interval. And by where we mean that, where is this services is being provided, at the HIV ART center, or primary care clinic, or other center, or at the community healthcare settings, or at the home settings. And who will be providing such services, whether it's a clinic physician, clinical officer, staff nurse, pharmacist, or a community health worker, or a client, or a peer, or the family member who is providing this treatment. And what all services are being provided, whether it is ART initiation or refill, or only the clinical monitoring parameter is required, or we just want to give our patient adherence support, or only for the laboratory investigations, or we just have to manage OIs for that particular visit, or we just have to provide the psychosocial support to our patient. Next, please. So, when, where, what, and who are the questions to be delivered for a for the person who is living with HIV. So, by when, supposedly we have done the monthly or bi-monthly visits, or every third monthly, such visits are reducing the frequency of ART refills and clinical visits. By this, we can utilize our maximum duration of ART refills, and we can extend or adapt the services hours for the patients. And by where we can decentralize the ART services, which can be brought closer to the home, like we have linked ART centers, which are bringing services closer to the home, at where patients are residing. And by whom these services are being provided is actually going to the is actually highlighting the importance of the task shifting, dispensing versus distribution of ART, and who are all the cadres who are actually going to play the vital role for this dispensation. And what services should be offered? Do the stable patients still need regular clinical consultations, or they just have to go for the refilling of the ART? So we are going to answer these questions by the differentiated service delivery models. Next, please. So, differentiated service delivery model one, which was actually the HIV centered, there needs to be a transition from HIV focused differentiated service delivery model to a um, patient centered differentiated service delivery model, which is actually inclusive of additional clinical services for people who are actually clinically stable for and only and they just wants ART refilling. So differentiated service delivery model 2 is a patient centered approach, which actually simplifies and adapts HIV services across the cascade, and serves the need of people living with HIV better to reduce the unnecessary burden on the healthcare system. This is actually often this actually includes prevention and treatment for tuberculosis, or routine preventing and providing primary care for family planning and for other non-communicable diseases services. Next, please. So this actually this patient-centric differentiated care package for retention. This topic is being covered in the National Operational Guidelines, Chapter 4, which you can all refer for further information and clarification. This is published in the 2021 guidelines. Next, please. So there are various stages of loss to follow up of patients who are registered in the ART center. This can be at the time of diagnosis of HIV to enrollment in care. The patient can be lost to follow up in the ART center when they are about to be initiated with antiretroviral therapy, or during the any course of treatment where the patient is likely to be lost to follow up. So we have to address these issues. That is why the differentiated service delivery model is being come up, so that we can improve the retention of patient in the HIV care. Next, please. So by retention, patients actually they are vulnerable for loss to follow up in initial 3 to 6 months of their ART initiation, and the major causes includes side effects of ARV drugs or certain gaps which are not being addressed during the preparedness counseling sessions, and those unaddressed gaps or not adequate preparedness for ART could be a possibility of the loss to follow up, and it is possible to identify probable loss to follow up and counsel them adequately. And by these differentiated models we can actually apply our resources, and we can concentrate more on such potential clients who are likely to be lost to follow up in such categories. So this framework for patient-centered differentiated care, this describes the patient-centric strategies for a package of services anchored in the life cycle of people who are living with HIV, and patient-centric strategies to augment the retention. So this is actually based on their needs, clinical status, and duration of ART, and this provides an opportunity to the ART center staff to prioritize and to look for the needs or the requirement of the special patient group. So at the time of when we are initiating ART, during the follow-ups, and if we identify certain issues, we can prioritize those issues, we can counsel those issues, and we can help the patient address those issues and improve the retention in the program. So this we are initiating we are going for rapid ART initiation, and early case management is being done. We are doing the regular follow-ups, and we have to go for the tracking or the tracing of the people who are actually missing their due appointments. This is actually going to address the early retention phase of the patients when they are being initiated on ART. And then by providing differentiated care, we can help them for the long term retention in the program. So the patient centered centric services across treatment cascade, actually by this we have a different packages which can be considered for the patient centric differentiated care. And this consideration is actually based on the whether the patients are newly initiated on ARTs, and whether it is a duration is less than 6 months, or whether they are with the advanced disease, or whether they are virally suppressed or stable patients, or whether they are virally unsuppressed, um, uh, or in the clients who are likely to be missed or lost to follow up. And so at the time of the enrollment in the care, we need to provide certain preparedness counseling sessions, and we have to screen for various opportunistic infections, and to provide the rapid ART after ruling out any opportunistic infection if it is there or not. And we have to go for we have to provide the patient centric packages, which will be addressing the particular case management, and we should be doing the intensive follow up for initial 6 months, and then the subsequent packages will be decided after this, as the patient is progressing with the treatment care. So these packages, the package A, the patients who are newly initiated on antiretroviral therapy, they will come into the package A services, package A or package A plus services. This is based on whether the patient has advanced disease or not advanced disease. We are going to provide patient with the preparedness counseling. We are going to screen for OIs and tuberculosis, and after ruling out, we are going to start with the rapid ART, and also providing the prophylaxis therapy for tuberculosis and for other opportunistic infections. And viral load will be done at 6 months interval. So the patient is asked to get the index testing referrals, and patient centric packages will be provided as per the population identified. And package A plus will be the individuals who are with the advanced disease. By this we mean that patients have the CD4 count is less than 200, or they have any stage 3 or 4 illness. So these patients who are actually identified with the advanced disease, they need to undergo enhanced adherence counseling sessions, and their approach should be different from the people who are in the package A. And once the viral load is done and patients are found to be virally suppressed, they come into the services of the package B, where we can, if the patient is stable on antiretroviral therapy and with viral suppression is there, we can go for a multi-month dispensation, and we can decentralize ART services for this particular client, and we can go for a routine viral load testing at a as per the programmatic conditions, that a routine viral load at a year interval can be done for such patients who are stable on antiretroviral therapy. And under the package C, we need to go for viral load testing and utilization services as per the these patients may be requiring enhanced adherence counseling because they are missing ART, or they are coming under the loss to follow up categories. They require a special care. These patients require patient centric packages depending upon their needs, and we need to go for a case management approach for focused and individualized care for such patients. We need to go for a monthly phone reminders to such patients. We need to have their additional peer support to enhance their adherence, or we may need to go for a home visit for such patients who are a potential missing the ART, or are the potential loss to follow up patients. And we need to track such patients for their missed appointments, and we may need to provide the advanced disease management to patients who are into the package C categories. I am going to describe you these packages more in the subsequent slides. Next, please. So, as I've just mentioned, for package A services, that as we know that most of the loss to follow up and deaths, these occur during the first 6 months of ART, after ART initiation. So this is most commonly due to the poor understanding, as I just mentioned, that they have not understood the role of ART therapy and various other things while we are explaining to them for the antiretroviral treatment and continuation. So, or they may be developing adverse effects to ART, and they just stopped coming to the ART center for various adverse events which has occurred with the ART, and those issues were not addressed timely. Or there may be some opportunistic infections, and they are they are taking multi pills at the same time, or there is some delay in the ART initiation, so they are potential to loss to follow up. So first 6 months are really crucial for any of the patient who is being initiated on antiretroviral therapy. And effective ART preparedness counseling and proactive follow-up of such individuals in the initial 6 months, this may lead to the improved engagement and retention in the care. So this package includes the proper preparedness counseling for all patients, with a specialized focus on identifying individuals who are likely to become lost to follow up, as we might come across the patients who are having the substance abuse, or are migrants, or adolescents, or key population who are actually or the individual is having the active drugs or substance abuse, or residing far away from the center areas, or are residing in the hard to reach areas. So we have to actually address that preparedness counseling for such issues should be done adequately. And we need to go for address verifications. We need to identify the caregivers. 4S screening should be done. Rapid ART initiation after ruling out OI, and TB preventive therapy after if the 4S symptoms are negative, that can be provided. We need to go for case management, intensive follow up for 6 months at least, with tracking and tracing. And cotrimoxazole prophylaxis, if found eligible as per the guidelines, is to be provided. So, and intensive follow up for 6 months is to ensure the retention in the treatment care. And viral load testing and utilization for patients on ART for at a 6 months interval. So by package A plus services, these are the this is for the patients who are with the advanced HIV disease. And in addition to PLHIVs, those with the higher potential to become LFUs may be considered for package A plus services. So there's a mechanism of tagging the white cards with the yellow stickers for package A patients. And if the patient is with the advanced disease, the tagging yellow sticker can be tagged, and then we can put a plus tag on such patients who are in the advanced disease categories. So for these patients, when for the initial 6 months, when we have to follow up our patients very religiously, and every 15 days for first 3 months telephonic tracking should be done, and then for and then once a month up to 6 months of the ART initiation. And in case patients they do not turn up, timely measures for tracking and retrieval should be taken, like if you have done telephonic tracking and then still patient has not responded, home visit can be done. And for patients who are identified under package A plus, similarly you have to go for the similar tracking and uh, follow up retrieval activities. For triaging patients to package B or C services, so we need to go for viral load testing. Which should be done at 6 months interval, then at 12 months of completion of ART. And depending on the viral load test result, patient should be categorized as stable patient or an unstable patient. So these patients should be assessed who have completed 6 months of ART, and staff nurse or counselor should assess such patients. So patients who fulfill the criteria of having a stable, they should be kind of, they if they have viral load suppressed, viral load is target not detected, these can be categorized as a stable patients. And then they will come into the package B services for a future program. And those patients who are still virally unsuppressed or unstable or having any other opportunistic infection or co-infections, and they are not found to have a viral suppression, they are categorized as package C. They will be categorized for package C services. These may be the individuals who are missing their appointment. These may be the individual who are adolescent. These may be the individuals who are pregnant. These may be the individuals who are likely to miss their due date. These may be the individuals who are having current substance abuse, or are into the high risk categories. So package B or C, if more than a patient has taken from more than 6 months antiretroviral, we can categorize after this. So for stable patients, for adolescents and adults who are, adults all above, these patients who are on ART for at least 6 months, and they don't have any adverse event with antiretroviral therapy. There is no adverse effect reported. There is no current opportunistic infection or co-infection. There is no other medical condition which is actually mandating their repeated visit to the center, or and they have suppressed viral load, and there is a documentation of the rising CD4 count as well, and their adherence is reported to be more than 95% consecutively for at least 3 months. So these are the individuals who can be categorized as a stable patients. Under the children category, who are above 2 years of the age, who are on ART for at least 6 months, and who are virally suppressed, and their adherence is more than 95% for at least for last 3 months, and they are on the same regimen, and the treatment regimen has not been changed for any of the reason, and there is no current illness or no current opportunistic infection or any other medical condition which requires a repeat visit or further follow up in the clinic. So these children will be categorized as a stable PLHIVs. And this definition of stable patient, this is applicable for patients on any ART regimen. It may be first line ART, second line or third line ART. after they are on that particular regimen for at least 6 months. So इसका मतलब है कि 6 महीने से वो वही treatment ले रहे हैं and they are stable, they have good adherence with no opportunistic or co-infections. So this definition shall be applicable across various differentiated models. So maybe multi-month dispensation or decentralization to the linked ART centers, or there are other examples of community-based dispensation for such individuals. And benefits of multi-month dispensation should be extended to the patients who are stable, and these services can be availed at LSC or LSC plus centers. And people who are on tuberculosis preventive therapy and who have completed 3 months of IPT, they could also be provided benefits of differentiated service delivery models if they are stable and are fulfilling the above criterias. And they should be actually provided with the proper counseling for adherence and for adverse effects if there is any. So to triage patients to package B or C, this depends on basically viral load test result and other criteria if they are fulfilling for being stable or unstable. So staff nurse or counselors will assess PLHIVs who have completed 6 months and who fulfill the criteria. This will be labeled as stable. For such individuals, their white cards can be tagged with the green stickers, and they should be triaged to package B services. And those people who are not fulfilling the stable criteria, these will be they will come into the package C services, and their white cards can be tagged with the red sticker, so that they should be under the close follow up and monitoring. So stable and unstable, having stable or unstable criteria, this is actually dynamic, and this should be assessed during each visit when they are visiting the ART center. And when we are interacting with the patient, we should be this stable criteria or unstable criteria, whether they are fulfilling or not, can be assessed. So just to give you an example, supposedly a patient who is on ART and now has completed 6 months of ART and has come for viral load test, which is found to be target not detected. So, which package of service can be provided to such patient, and what services would be provided to this patient would be, next please. We can provide such patient with the package B services, because Dr. Hemant, now this patient has come up with the viral load suppression, target not detected, and is on ART for at least 6 months. So as per the criteria of triaging patients, now if the patient is virally suppressed and is on ART regularly and with the good adherence, so this patient now comes into the package B services, where we can consider this patient as stable since adherence is good and his viral load is target not detected, and we can go for multi-month dispensation to such patient, and we can also go for linking such patient to the center nearer to his or her place, and we can even go for a community based refill group if patient wants to go for that refilling. And for all patients who are on first line ART, and their routine viral load should be done at firstly at 6 months, and then at 12 months after ART initiation, and after that we are going for annual viral load testing for such patients. And just to mention that white card of such patients can be tagged on the green stickers, which is again we have to assess for such patients at each visit whether they are still fulfilling the criteria of being under package B or not. So I hope I'm making you understand this triaging by package A. When we are initially initiating ART, patient will come into package A services. If patient is having advanced disease, stage 3 or 4 illness, or with the CD4 less than 200, this patient will be package A plus services. So by package A and package A plus services, in package A, as I just mentioned, we have done for preparedness counseling, we have assess the patient for various opportunistic infection, and then we have done the rapid ART as there is no OI found in such patient. And Such patient will be at monthly follow-up for at least 6 months, and then whereas for the patient under A plus category, such patient was having advanced disease, so this patient will be given advanced disease package services, where patient will be treated for various opportunistic infection, stage 3 or 4 illness if it is there. I'm sorry. And then at 6 months, when we have done the viral load test for our patients who are newly initiated on ART, and now this viral load has come out to be target not detected. So now this patient who is having good adherence can be offered package B services and can go for multi-month dispensation, or we can decentralize the services. We can link this patient to linked ART center wherever patient wants to be to get linked or not. And under package C services, we have to go for patient centric approach. We have to uh, address the client centric approach. We have to provide such patient, we have to closely monitor such patients since they might be under the category of missing their ART, or they may be they may have some other we have to actually follow the patient centric package under the package C services. Next please. So for the stable patients, ART 3 months dispensation can be done at one go. Follow-up visit will be done to reassess for stable criteria if it is being fulfilled by the patient, whether the patient has taken ART as advised, adherence was more than 95% or not, and when is the viral load due, when is the CD4 count due for such patients. And if again patient was found to be as per the criteria, we have done the viral load testing and CD4 testing, and if the viral load is found to be target not detected, patient will continue under the package B services. But if the viral load is found to be high in the subsequent visits, or if the patient is found to have any infection while being on ART, this dispensation can be, I mean, this approach can be shifted to the package C services. And if a patient on multi-month dispensation, they do not turn up for their drug pickup as they were expected to come on their due date, so a call should be made within 48 hours of their missed appointment. This list can be shared with the care support centers for home visit by the end of the week if the patient still not come, and we can label such patient for miss or LFU as per the existing guideline criteria. Like if the patient has still not come up for a month, he will remain under miss category. For next month also miss category, and after 3 months this patient will be categorized as a LFU patient. So this is an example. Now I'll be telling you about the example of community ART team, yeah, community ART groups by this. These are actually the community ART refill groups. These are the self-forming groups of stable PLHIVs from the same geographical area, maybe adolescents, only, or family units, or community group or network, or members of a specific key population. These are managed and facilitated by PLHIVs themselves, or by the community members, or the peer person, or a PLHIV network, or by CSCs, CBOs, or target intervention NGOs, or the service providers, or the link workers. So these groups are formally registered at the ART center, and along with the details of the focal person and all the group members who will be the part of that community ART refill group. So these can be formed by a community itself based on common need for care or geography, or ART counselors or other providers can also identify and support information of these groups and orient the group members on the standard operating procedures of such group and reporting requirements. And these groups can be facilitated by the PLHIV network. So ideally, next please. Ideally, a group of these have 10 to 30 members. However, number may vary based on the local context and may be smaller in the rural or in the hard to reach areas. These, as I just mentioned, that these groups are registered at the ART center along with identified focal person, and the group members are also identified, and these details are being shared when they get registered at the center. And patient should be willing to be the part of this community ART refill group. And all the members should be willing to disclose their status to each other and should be fulfilling the criteria for having for being the stable PLHIVs. They should be those who have the viral suppression. And however, certain times what happen, like if some non-adherent PLHIVs can be this can be considered on case to case basis, depending upon their assessment at the ART center. This group to identify a focal person who will function as a link between ART center and the community ART refill group. The group members can take turns to be the focal person, and however, other members of the group, they should not be changed. So one member from the group, uh, this will be actually representing the whole group and collecting the ARVs for the whole group from the ART center upon providing the adherence details, forest symptoms details, or any other symptoms, if it is there by the member or not. And counselors should follow this community ART refill group at ART center for adherence, for the status of members, and any action which is required for any of the member. And the counselor shall also actually be updating the adherence and other relevant details in their original white card as well. And it is actually to be ensured that each member of the group should visit the ART center at least once in 6 months for actually being examination, consultation, and necessary investigations um, in this group. So as I just mentioned, the focal person will be going for timely ART pickup and refill, and will be actually assessing for 4S symptoms if any of the member is having. And if any OIs or adverse event or antenatal care is required, this will be actually going to be shared with the center when they will be coming for the when actually the focal person is visiting to the center. So this actually focal person will also ensure timely visit by the members as well. And the members of that community ART refill group should maintain good adherence, and they should attend the group meetings, and they should visit the ART center as per their scheduled visits and all, and inform the focal person for any of the concerns, like if they are having any of the opportunistic infection symptoms and all, they should be informing to the focal person. And if some of the member is pregnant, that person should also be informing the focal person, so that that can be conveyed at the ART center, and the timely visit can be organized for such patient. Next, please. So, under the package C services, as I earlier mentioned as well, that those patients who are having unsuppressed viral load, they would be actually requiring step-up adherence counseling, and a repeat viral load is required at 3 months interval for such patients, and they also be requiring the e-referral to SASA for review for second or third line ART. So, these individuals come under the package C services. We need to go for case to case management in such cases, and individualized approach is required for patients who are under the coming into the package C services. There may be individuals who are into the package C who are in the advanced disease, so advanced disease management can be required for any of the patient who is into the who has taken ART for more than 6 months and still viral load is unsuppressed, or having any of the advanced disease illness, stage 3 or 4 illness. And white card of such patients who are categorizing into the package C, this should be actually appropriately tagged red, and they require optimal follow-up for enhanced support and services. Next, please. So, to manage patients with the unsuppressed viral load, like viral load is above 1,000 copies, they should undergo step-up adherence counseling for 3 months. So, and when viral load test report is available, and we get to know. We get to know that patient is having high viral load. This viral load list is generated on a daily basis. So this list should be shared with the counselor who are delivering services under package C to such patients, so that call can be made to such patients to report to the center for assessment. And counselor should provide intensive support to improve the adherence to such patients. A minimum of 3 sessions, which can be 15 days or 1 month at interval. These are recommended for step-up adherence counseling, but additional sessions can be considered for patient as and when required. And it is actually preferred that the same counselor should be providing the enhanced adherence counseling session to those people who are having high viral load. And these sessions can be planned when the patient visit the center to collect the medicine as well. And step up counseling should be done for such patients. And supposedly a PLHIV is not able to come to center and is on multi-month dispensation. So such 3 sessions of step-up adherence counseling, these may be done telephonically with proper documentation. And and uh, and we should be actually trying to make a early visit for such patients, so that we can even physically examine such patient for any of the OI or any other co-infection at the same time. And same time, like patient supposedly was under the multi-month dispensation category, now this patient should be shifted to the package C services. So, a repeat viral load testing must be done for such patient after 3 consecutive counseling, step-up adherence counseling session. And if the step-up adherence has been done and now the adherence has improved to more than 95%, so a repeat viral load testing should be performed after 3 months for such patients. And if in the repeat viral load testing patient after the step-up adherence viral load will come out to be less than 1,000, so patient can be recategorized as a stable patient. And we can advise to continue on the same treatment guidelines. And if after the repeat step-up adherence counseling session, repeat viral load still come out to be more than 1,000 copies, so or the virological failure is there, such patient should be referred to CESUP by e-referral within actually 2 days of receiving the viral load report. And CESUP should review these cases and share recommendation with the ART center within 1 week of the referral for ART switch if it is required for such patients. So, case management for individual approaches can be by the monthly phone check-in by the counselors. SMS reminders should be done, and a home visit can be done for case-to-case basis by peer counselors or outreach workers, so as to ensure adherence. And peer counseling support for disclosure, stigma, gender-based violence, or intimate partner violence, that support should be provided, so that patient can come out with such issues if it is there. And patients who actually return to the center after being missed or lost to follow up, they should be actually catered closely, and they should be provided a friendly and welcoming environment, so that there are factors which makes them to miss ART or lost to follow up. These should be addressed, and so that they should not further miss their due date, they should be provided with the friendly environment in the center. So for the unstable patient, we should be providing with the adherence support system, especially if poor adherence was due to some barriers like their routine clinical visits was challenging because of the long distance travel or financial reasons, or there is non-availability of any of the caregiver or support, or the timings with work or school are not matching with the ART refilling. So such patients, if identified and they have issues reporting to the ART center, these may be linked to their linked ART center on case-to-case basis, and enhanced adherence and counseling can be provided by the counselor for further adhering to treatment regimen. But this can be decided on case to case basis for those patients who for those who identified with these reasons. And also at the same time, we should be having a follow-up mechanism of linking these patients and at linked ART center also. And community-based sites may be preferred in such scenarios where we can provide with the additional support for care and treatment for those patients who are having these issues. So this is actually giving a differentiated care to the patients who are unstable or having a high viral load, and they were not reporting to the center because of their these reasons which have been mentioned. So differentiated service delivery models could be an individual model or a group model. So group model can be managed by healthcare workers, or by the managed by their clients, I have just given you example of community ART refill group, or community-led ART delivery TI sites. Individual model, this can be based at the facilities, at the linked ART center or orphanages, or one stop center for transgenders or the key population. Or individual models can be can these may be at fixed community points where the patients can be provided with their services. This can be a home delivery, can be a mobile outreach ART delivery model, or this can be a fixed community point like at churches or railway stations and some certain areas where it is there. Next, please. So these are various examples of differentiated service delivery model interventions. These such Mitwa initiation is at Mumbai for adolescents who are living with HIV. There can be optimized decentralized ART delivery model based on the patient's residence, and which is there in Andhra Pradesh. So there is one of the model for female sex workers also in Andhra, and there are welcome back clinics um, also providing differentiated care to enhance the clinical care and viral load suppression among children and adolescents. And also there are certain models of closing equity gaps among key population and children who are living with HIV in Andhra. And one is retention in care calling activity in Mumbai, and one stop center and health on bike is also there in Mumbai, Manipur, and Nagaland. So these are the various examples of interventions by differentiated service delivery model, which could be an individual or which could be a group model. So this was all about the differentiated service delivery model. I thank you all for your patient hearing, and if there are any questions, please let me know.
Thank you so much, ma'am. Any questions from the participants? किसी को कुछ पूछना है differentiated service delivery models के बारे में? Any questions from the participants? Oh, ma'am, I don't think there are any questions.
So if there's any question, they can even text me or chat and put in the chat box. I can even reply later as well.
Sure, ma'am. We'll do that. Thank you so much, ma'am, for facilitating this session. Thank you to all
Thank
the participants for patient listening. Ma'am, can we conclude the session now?
you. Yes, thank you so much. Thank
Okay,
you,
thank
Shweta.
you.
Thank you, iTech.